talked about that in your, as you started ER Med, have you covered this, anything? Okay, well, that's good, because I have some, well, I mean, it's not good, but I've got ClinMed in mind, so we can use it as a context. So let's start with, what do you remember about asthma? So this was, I don't know when we did poem, number 4, April, March, April. So let's get our brains wrapped back around asthma. So what is asthma? An obstructive, reversible disease. Okay, what did you say, Boone?
Oh, I think it's constrictive, but I think you're right.
Okay, what else? As opposed to restrictive, it's not restrictive, it's obstructive. Okay. So what part of the lungs are usually affected? Say again. Be bold.
Bronchioles.
Bronchioles, probably even further down. Bronchiole.
Alveoli.
Yeah, no, not the alveoli, but the little bit airways right before the alveoli, so the bronchioles. Okay. So what happens to them?
Mucus plugging?
They what? They get plugged. I heard that.
Constrict.
Plugged with mucus? Is that?
You get mucus. Here's the outside of that bronchiole. What's the next layer in? Smooth muscle. Okay. So, and then in here so with that smooth muscle, what innervates it?
Sympathetic.
Sympathetic nervous system maintains the tone usually in asthma. Okay. There are goblet cells in there. What do they produce? Mucus. So you get mucus. This becomes hypertrophic. Okay. So what happens to the caliber of that airway?
Small.
Does what?
It's smaller?
Cheap chunk.
It's smaller, so what happens to resistance? Pardon? Resistance. So, resistance, even small amounts of changes in resistance really do impair airflow. So what are you going to hear? If you're going to listen to the lungs of somebody who has asthma, what are you going to hear?
Wheezing.
Wheezing, so very high-pitched, and that's because those airways have gotten very small, okay? So how does it impair them? What kinds of how would you tell if they were impaired? So you've listened to them, you've heard wheezing. Is it usually focal, localized, or diffuse?
Diffuse.
Usually diffuse, okay? So how would we measure that? What are we going to use to tell that that's the case? You've heard it, now what are you going to do?
O2 stats.
So you can do pulmonary functions, or you can do a pulmonary expiratory flow rate. What would you expect to see? Pardon? Can hear you. So is inspiration a problem for them? Can they get air in? They can get air in, they can't get air out, okay? So their expiratory phase is prolonged, right? So you can get rid of a large percent of your expiratory volume in 1 second. If you take a deep breath, we did this before, and you blow out birthday candles, you can do it in about 1 second. So you take a deep breath. I can get rid of 70 to 80% of that volume in 1 second. So that's your FEV1, right? Forced expiratory volume. Okay. What about them? Can they do that? No. So it's prolonged. So they have a very prolonged expiratory phase. Okay. What other symptoms go along with asthma? So we hear the wheezing. What are they going to complain about? How are they going to present?
Shortness of breath.
Shortness of breath. So there's a triad. So shortness of breath.
Tachycardia.
Tachycardia is something we would measure. What other symptoms are they? They're not going to come in complaining of tachycardia. So they're telling you risk factors, so they have risk factors. So shortness of breath, what are the other two?
Coughing.
Coughing,
Fatigue.
chest tightness, okay? Fatigue would be another symptom. So those are the three. They are not, they're not pathognomonic well, they are for asthma. When you hear that, you ought to think asthma, okay? What are the major drugs we use for asthma? So we have corticosteroids and we have what? Bronchodilators, okay. So bronchodilators make sense because we want to relax those airways, right? That relieves the constriction, we can move air in and out. But that's a symptomatic treatment. What is the basic problem in that airway?
Inflammation.
Inflammation. Never forget that. If you treat the symptoms, the inflammation will never go away, you will never get good control, and you put them at risk for exacerbations. So we always use a anti-inflammatory unless we have extremely infrequent focal or local, very discrete reasons for their asthma symptoms. Which would be what? What would be more likely to be an intermittent, only occurs a few times a year? What would it be? It's usually allergies, and the most common ones would be what?
Hay fever.
Dust, mold. Usually it's animal dander in those. It's when they come into contact with just that allergen. So it could be seasonal. So it could be in the spring or the fall, this time of the year, or animal danders, dust mites, roaches in the house. Those are common causes. Okay. So only in those circumstances do we just use a bronchodilator. Everybody else gets an anti-inflammatory. Okay, so how do we know if what we are doing is working? What are the big monitoring parameters we use?
How much are you using?
Okay, so number of exacerbations.
How much are you using albuterol for your rescue?
How often you're using albuterol, which you said is your rescue inhaler. What else?
They wanted to go to like the ER where you couldn't catch your breath.
Okay, so how many trips have you made to the ER, urgent care, unplanned visits to the doctor? Okay, what else?
Waking up at night.
Waking up at night, very important one. So waking up at night with symptoms of asthma that you have to grab your beta-2 agonist and treat. Really important. Okay, what else? Pardon? Infections. Infections, okay. Not something we usually monitor, but would be an important trigger. Okay.
During exertion.
Okay, so are they having problems on exertions like with exercise? What about peak expiratory flow rate? Okay, so what's normal? What is our goal for everybody with asthma? Our target. This is important because this we're going to use when they're coming into the emergency room. So peak expiratory flow rate should be at least what percent of normal?
Maybe 80.
80 and above, okay. So what's the next category? What's the at-risk category?
60 days.
A little bit higher, so about 70, in the 70 range is is caution. What's the high risk? 50 to 70 is high risk. I mean, is at risk. What's the highest risk?
Below 50.
Less than 50%, okay. All right, let's see. The other would be that somebody alluded to, but we didn't fully go into, would be limitation of activity. So if they cannot take part in their task of daily living, that's a problem. If children can't play, if they can't run, if they can't go outside, that's a problem. How many days of school they miss? Do you remember how many days of school we talked about on average that kids miss with asthma? Due just to asthma?
30.
100's a little bit high. 13, average 13. But that's 3 weeks. That's 3 weeks. I may have said 100 for something else, but about 3 weeks just for asthma, that's a lot. That's a lot. If you look at a school year being about 36 weeks, that's a third of the school year, okay? Increased missed work for adults, common. One of the most common causes of disability and early leaving the workforce is asthma in adults. So it's very common. You will see it. I don't think you can hide from it. It's too prevalent in our society, and it's one of the most common chronic illnesses of childhood. Let's see. I think that's most of it. Okay. Anything else you remember or questions? Okay. So, if you are doing your job and the patient is adhering to what you say, most of the time they will stay out of the hospital because of your efforts and their adherence. Okay? Education is a huge part of it. Okay? Expectations and goals, huge part of it. Negotiating those with parents and with the patient is really important. I can tell you that in dealing with asthma over the years, I have found that patients learn to set a very low bar. I had a patient one time that once we got her stabilized and we got her very asymptomatic, she said, I didn't know you could be like this. She was probably in her mid-30s. She said, I just thought that people with asthma always wheeze. She said, most people in my family have asthma and they all wheeze. And I just assumed that was the life of an asthmatic. So I always painted a picture for a patient, this is what your life should look like. And so that they could shoot for that and know that that was possible, because most people in this country are undertreated for their asthma. And so they just accept that that's just life. When it's cold, I wheeze. When I get into contact with this, I wheeze. And I feel short of breath. And I can't always do everything everybody else can do. I'm telling you, that's a danger. If you let patients accept that, then you're putting them at risk. And hopefully today will kind of drive that home, because those persistent undertreatment are at higher risk for the morbidity and mortality of asthma. I am passionate about this because 2 pharmacy students, I told you about this when we talked in pulmonary, when I was at the college, died of asthma. And we're going to talk today about slow onset fatal asthma, and that's what both of them had. That's usually undertreated, poorly controlled asthma that just deteriorates over a period of several weeks. Both of these women on the weekend, asthma got bad, they both got in their cars, tried to get to help, died on the way. Okay? These were kids your age. Didn't need to happen. So I see it over and over again in practice, especially in the under-resourced or resource-poor group, is just chronic, poorly controlled asthma. Okay, so let's start, and we're going to talk about COPD. We have covered that material before. We'll go back over it at the end, but that information is less new. So I'm going to play you a video. This is a person who's come in to the emergency room with asthma. There were several good ones to choose from. This one is, is very typical. I want you to look at the man, how he's presenting himself, how he is trying to cope. And it's kind of like in the dentist chair, you know, they just constantly ask you questions the whole time. He's asking this guy questions the whole time and he can't answer. He just doesn't have enough breath to do it. This is a guy with pretty severe asthma. Okay, Brad, what do I have to do? I set this up upstairs and I'm having trouble with it. Oh, here we go. So you just had to start this way, it was so hard.
I'm Dr. Olson, how you doing?
See how he's sitting?
Having trouble breathing? Just breathe this in, okay?
Ramon Fargas is a chronic asthmatic.
1 to 4 probably, right? That means he's got pretty bad obstructive disease. Have you ever been intubated before? How many times?
Very important question.
4 times? He is having a severe asthma attack, and he's got a history of asthma. He's been put on a ventilator several times before, so he has the potential to get really sick really quickly. And he's having trouble breathing right now. We're going to put him on a machine that's going to help him breathe and open up his lungs a little bit. Just hang in there. Focus on breathing. You ever been on the CPAP machine? We're going to put
See
you
how
on
hard
that
he is
now,
working
okay?
at it?
Is this
Using
one of
his
your
whole
worst
chest?
attacks
Do you breathe
you've
like
ever had?
that?
Or you've had worse? You've had worse. All right, that's good, Dad. The worst thing for these guys is when they can't keep up with their own breathing, we have to put them on a ventilator. We have to sedate them and what's called intubate them, which is put a tube down their throat to help them breathe. And they get a lot of other problems associated with that. Infections from the tube, they lose their ability to breathe on their own, they have to go to the ICU for several days. So it's much better if we can avoid doing that.
But Ramon can barely breathe. It's going to be a fight to keep him off the ventilator. But the chest x-ray shows Dr. Olson's suspicions were correct.
He's got a pneumonia, gnarly looking pneumonia. And he's got cephalization too. It looks like he may have a little bit of component of failure. It looks like you have a pneumonia on the right side of your chest, okay, in addition to the asthma symptoms that you're having. Deep breath. Okay, good. He's sounding a lot better than when he came in. He looks a lot more comfortable than when he came in. So we're going to admit him to probably a monitor setting, probably telemetry or ICU, just to keep an eye on him overnight, make sure he continues to get better.
Oh, let me show you this kid. I wasn't going to put this one in, but just watch how hard he works at this. So look how they're sitting.
15-year-old
He uses a
Chris
lot of
is having a
retraction.
severe asthma attack. His immune system has made what could be a fatal mistake
Yeah, dusky.
and is shutting down his airways. Without help from the medical team, Chris's body may shut down completely.
You're not going to die. You're not going to die. You'll be okay.
Chris's allergic reaction has tricked his immune system into shutting down his airways, blocking vital oxygen to the rest of his body. The drugs are supposed to help the muscles around Chris's airways to relax, but there is a problem. The mucus stops the drugs from reaching his blood
The
supply.
bone to try and help it out. Because sometimes the lungs close down too much for this stuff to work. So
Time is running out. Chris's body takes emergency action. His shoulders and neck muscles swing into action to help inflate his lungs. But even this is not working. As the pressure mounts, the team must find a treatment to get the drugs past the mucus. Chris is by no means an isolated case. 1 in 9 Australian children suffer from asthma, but for Chris, the situation is looking dangerous.
Chris is currently having Ventolin or salbutamol through a nebulizer, which he's breathing into his lungs. This acts on the muscles around the small airways and helps to open them up. Unfortunately, sometimes when the airways are very closed down, the salbutamol doesn't reach the areas that it needs to get to. The inhaled Ventolin is not working, then we often will
You
go
can
to a
see
different
how
form
his
of
breaths are
medication.
shallow
Again,
because
a
they get
relaxant
so
for the muscles
hyperplugged,
around
they just
the
can't move a lot
small
of air
airways,
anymore.
and it helps to open
And
those
they get a
airways
lot of
up.
plugging,
And it's
so
given
they
as a
just
one-off
can't get the
dose
air
over
down
about
into
10
the
15 minutes
alveoli.
in severe asthma.
Inside Chris's body, the airways start to open as the drugs take effect. Air finally returns to Chris's lungs, inflating the 300 million tiny air sacs.
Chris, feeling a bit better?
At last, he can
See
breathe.
his
Chris
retraction.
seems to be feeling a lot better now.
See, it
The
lifts that-
intravenous
these- those
medications
muscles
seem to have
that
taken
airway
effect. He
creates
still
more
is very
negative
tired
pressure
and
and
working
draw
very
air
hard with his
down in.
breathing, but we're a lot happier with his clinical progress.
Much
now.
better because he laid back down. Okay.
Chris was admitted to intensive care for 3 days, with a further 3 days.
Okay. Okay, so this first. This is in your handout on the next page. So the principles of care on page 2. One is assessing severity, because that's going to determine how aggressive you are going to be in your treatment. Also assessing potential triggers, remembering some of them are in this. Sometimes that will be helpful. What set this off? It could be that they haven't been taking their medicines. It could be they were exposed to some type of chemical fumes. Maybe it was at work. Maybe something happened at home. For kids, maybe it's someone was smoking more around them. Cold air usually isn't, pets usually aren't, but it can be a combination of these things. Always suspect a viral or a pneumonia are very common triggers also that can set them off. We're going to use bronchodilators very aggressively. We're going to use short-acting. We're going to use both the beta agonist and the ipratropium or anticholinergic if need be. And we're going to use anti-inflammatory. So those are your big ones. You're going to use usually an IV or an inhalation route for both of those. We're going to frequently assess them to tell us what their response to therapy is. And then the decision will be is, are you going to admit them? Will you intubate them? So those would be things that would follow. So under the initial assessment, I'm on the page 2. One is history. It could be that they are presenting and this is their first asthma attack or their first breathing problems that have been bad enough that someone has brought them to the emergency room. They may have had other episodes, symptoms. This may have been going on for a long time, but now they've gotten into trouble. So they could present to you for the first time in an urgent care or emergency room with asthma. We talked about recent symptoms, exposure to triggers. If we can get a peak expiratory flow rate, that would be helpful if a patient can do it. You can see these two people would not be able to do it. In more milder cases, you may be able to get one from them. Or you'll have a portable spirometry that the respiratory folks can bring in to look at that as well. Assessing adherence is so important because if they have overused, let's say they're overusing their beta-2 agonists, that's important to know because they may have just so depopulated their beta receptors that they can't even respond to what you're doing. Nowadays, we start steroids much, much earlier. That helps re-establish those beta receptors on their airways, and so they usually will respond better. But that's delayed. Steroids always take hours to work, and so we've got to use those bronchodilators if they are. If that's helpful, you're welcome to. Then a recent illness. You really want to look at, this time of the year would be flu. Has someone in the family had flu? Have you been exposed to flu? Have you been vaccinated? Pneumonia. Other people with viral illnesses in the household, or maybe where they work. School teacher exposed to kids, or in an area, another type of I'm trying to think where else. Maybe in other teaching venues, or where they're exposed to, like daycare workers would be another. Okay. So let's look at this table in terms of assessing their severity. So we have, we're going off the history that the patient's telling us, what you can physically examine. You're also going to do their O2 sats and a peak expiratory flow rate if you can get that. So we're going to look at moderate, severe, and life-threatening. So if you kind of go across each one, what you'll see is a further degressing or worsening of each of these. So can they talk to you? Can they pull enough air that they can speak to you in full sentences? Or can they only give you phrases, or can they not talk to you at all, like the two gentlemen I just showed you? How agitated are you? You saw the boy in the second one, he was anxious. He was so afraid, he's like, I'm gonna die. So that anxiety is very high. Or in that life-threatening, are they starting to lose consciousness, or loss of consciousness just due to the inability to oxygenate? Respiratory rate is important. So what's a normal respiratory rate in an adult?
12 to 20?
8 to 20, under 20 for most adults, okay? So here we've got a respiratory rate under 30. We've got severe as over 30, and then with life-threatening, also 30 and above. In terms of accessory muscles, so in the milder forms, they're probably not going to have to use that. But when you're getting to severe and life-threatening, they will do everything to keep moving that rib cage out, because it creates a negative pressure, makes it easier for them to draw that air in. But again, more like you saw with the second boy, is too much air trapping, too much inflation, can't get air, can't move a sizable amount of air in and out. Heart rate will go way up. Anxiety also. Why else would the heart rate go up? Okay, stress, but what is that heart doing? It's moving blood. Why do we need that blood moving through?
Oxygen.
Oxygen, okay. So you have these alveoli that are covered in capillary, right? And so that's where we are able to exchange oxygen and carbon dioxide, right? So if you have plugs, or if you have bronchioles that are so constricted that you can't get air into the alveoli, or you can't move it out, then what happens to your ventilation in that unit? It goes way down. You can't move oxygen in, and you can't take the CO2 out. So their oxygen levels start dropping, their CO2 rate. Depends on how quickly their respiratory rate, we're going to look at that in just a minute, is to how high their CO2 is going to go, if they get hypercapnic or not. So that's why that heart rate is going up. It's just trying to move that blood around faster and extract the oxygen that is available. So you can see their O2 saturations drop with severity. So what's a normal oxygen saturation?
96.
100. Okay, so very close to 100, right? So here we've got less than 92%. We're very concerned about. Peak expiratory flow rate, again, the two that I showed you, we're not going to be able to do that. But you can see that their peak expiratory flow rate, which is pretty similar to what you get with FEV1, is around 200 or less. You know what a normal adult would be? Nathan is probably 600 plus. Boomy is probably about 450. So in that range is a normal adult. Look at where theirs are, 200. Okay, so that air, being able to expire that air, is really low. Okay, be familiar with these. And the signs and symptoms you're going to look. What can you objectively measure? What can you observe in that patient? Questions about those? Okay, so under physical exam, this kind of recaps this. So tachypnea, greater than 30 a minute, tachycardia 120 and above. Use of accessory muscles. What would those muscles be? Here they are. Anything that can lift that rib cage up and out. So scalene, the trapezius, sternocleidomastoid, your pectoralis major, your intercostals, they really lift that rib cage up. Abdominal muscles, you saw that with both, well, you couldn't see it in the guy because he had a shirt on, but that boy, you could see the use of abdominal muscles also to move air out. Okay. Talked about the inability to use, have enough breath to talk in full sentences. Couldn't lay down. Neither one of them would lay down, would they? So they're hunched forward. They're positioning their body as well as they can to be able to move that air in. And you saw as the young man relaxed, and both of them, they were able to lay back. Have you done pulsus paradoxus yet?
A little one.
Okay. Let's look at this then. So pulsus paradoxus is something you can measure to determine, also gives you an idea of severity. You'll see different things, but this is a fall in systemic blood pressure by 10 to 12 millimeters of mercury during inspiration. And I brought this video to show you because I wasn't sure if you all have done this or not. Okay, that didn't work. Brad, I need you just to stand up again and head this way. Okay. Now I got it. I have it set up in
Try control and then click.
control what?
Control and then click the link.
Okay, thank you.
Welcome to the Stanford 25 video on Pulsus Paradoxus. Pulsus Paradoxus systolic pressure drop greater than 10 as a systolic pressure drop greater than 10 with inspiration. Normally, during inspiration. Welcome to the Stanford 25 video on Pulsus Paradoxus. Pulsus Paradoxus is defined as a systolic pressure drop greater than 10 with inspiration. Normally, during inspiration, the decrease in intrathoracic pressure will cause an increase in blood flow to the right side of the heart, leading to an increase in pressure transmitted to the right ventricular walls. Since more blood remains in the lungs during inspiration, a small drop in systolic blood pressure is expected. However, in tamponade, the increase in blood flow and pressure on the right ventricle during inspiration cannot be transmitted to the right ventricular wall, and is in turn transmitted to the ventricular septum. This in turn leads to a decrease in left ventricular filling, which causes a decrease in stroke volume and a much lower systolic blood pressure. To measure pulsus paradoxus, all you need is a stethoscope and a blood pressure cuff. To test for pulsus paradoxus, slowly look for the first Korsakoff sound that will appear, then disappear during inspiration. Next, slowly listen for when the first Korsakoff sound no longer disappears with inspiration. This clip was recorded from a patient at Stanford University with a pericardial effusion. Pulsus paradoxus can be a valuable clinical tool and has been shown to have a sensitivity of 98% and a specificity of 83% in predicting cardiovascular compromise. Along with tamponade, pulsus paradoxus can be seen in some patients with constrictive pericarditis, during asthma or COPD exacerbations, and less commonly in other clinical scenarios. Importantly, pulsus paradoxus may not be present despite a patient being in cardiac tamponade in certain situations such as aortic regurgitation, and atrial septal defect. In addition to other findings such as an elevated jugular venous pressure, tachycardia, and shortness of breath, pulsus paradoxus can serve to be a valuable tool in the evaluation of a patient with suspected cardiac tamponade. This has been the Stanford 25 video on pulsus paradoxus. Thanks for watching.
Okay, so it's another piece of the information you can get. And I'll just tell you, in the times that I've taken care or been involved in the care of a patient in the emergency room, we didn't usually use it that much with severe asthma, but it is certainly another objective measure you can use. Okay, so let's review about peak expiratory flow monitoring. Again, it's very similar to FEV1. We talked about normal being what? Our goal is what in asthma?
80%.
80% and above, and danger, a more caution area would be what?
50 to 70.
50 to 70, and below 50 being a severe. So these are the devices that can be used for peak expiratory flow rate. This is a more portable one that can be used to capture FEV1 in the emergency room. So again, it will record the maximal outflow or expiratory breath. But it requires a lot of patient cooperation. That's why with these two patients it wouldn't have worked. But somebody who was more mild or moderate would be able to do that. They have to be able to give you their best effort. Usually you're measuring 3 of those best effort of how fast they can expel air from the lungs. So there's all varieties of meters. I think I brought one and showed it to you during asthma. So this little girl is showing breathing into the device, and it will move along a column. That's what each of these have, and will stop where their maximal flow was. There are charts then that you can use to determine what somebody's peak expiratory flow rate should be. If you look on the next page, page 4, I give you 2 charts, and these are for adults. They make them for children as well, that you can use to find out what a population for a given gender in height and age. So, Zane, would you give us your data here? How old are you?
I am 24.
So almost 25. So if you look at the top chart there, go to age, which is on the y-axis, 25. How tall are you?
6 foot.
Okay, so he's between the 70 and 75. So he's somewhere in the range of probably about 650 in terms of liters per minute. So he can blow out that much in that period of time. Okay? These are population averages. He may or may not be able to make that. He may be able to exceed that. Okay? For patients who have developed, let's say have had asthma all their life, they often will have lower lung volumes. So what we do is we establish a personal best. Remember that? I'm kind of going back to more chronic asthma. But that's how these are used. Boomy, will you give us your data? How old are you?
I'm 26.
Okay, so go down to the bottom. So we'll go with the 25 line. How tall are you?
I'm less than 5 foot, so about, yes.
Okay, let's go over to the 5 foot just to look at the 60 inches. So she's probably around 400. Okay. So then you take 80% of that. That's what you're wanting their goal to be, at least above that. Okay, see how that works? You'll note these are based on a mixed population, predominantly Caucasian. You'll note that they're in their underneath it says that predicted values for African Americans and Hispanic minorities are approximately 10% lower. Okay, just to review. Let's go on over to page 5 then. So oxygen saturation, so you've all done this at Good Shepherd, correct? I've seen you all get the O2, the little monitor, and put it on them, okay? So peak expiratory flow does not correlate well with oxygenation. It does correlate well with the level of CO2 in the blood. So you need both. You can't rely just on peak expiratory flow or FEV1 to tell you about their ability to oxygenate. So monitoring this would be a standard of care that you would carry out in the emergency room. If you look under that third bullet, what you're worried about is how hypoxemic are they. So a marked hypoxemia would be a partial pressure, an arterial pressure less than 60. Okay? So if we're thinking about 100 being normal, then they're quite a bit below that. And the O2 saturation being below 90%. So that less than 60 and less than 90 would be marked hypoxemia. So that's life-threatening. That's where those folks would probably be intubated in order to, particularly if they are, if they're wearing out, in order to keep them oxygenated. So hypercapnia. Now, why do they get hypercapnic? What is hypercapnia? What's hyper? Elevated. So capnia refers to what? CO2. Okay. So here, peak expiratory flow rates are usually pretty good about predicting that. So we're worried when their PaCO2 gets above 45. Okay. What's normal? Remember? 35 to about 45 is normal range. So we're looking above normal as being a problem. Hypercapnia is rarely present when the peak expiratory flow rate is greater than 25%. All right, so let's see if you remember some of this. Remember the Henderson-Hasselbalch equation? Of course you do. What is it? pH is equal to what? 6.1 pKa of blood plus what? The log, oh, come on.
No idea.
Okay, what's the fraction? The base. Okay, now you know this. pH, base goes up, pH goes up. What's in the bottom?
CO2.
I love this equation. If you'll remember it, you can go back and go, now how does that all work? Okay. This is just a dissolution rate for CO2 in the blood. These are fixed. CO2, this number, fixed numbers. These differentiate. So it helps you remember, as their CO2 goes up, what's going to happen to their pH? Down. They're inversely related, right? Okay. So for them, early on, that elevated CO2 is a respiratory driver, right? Yes. That's why they get tachypnic, is because that CO2 starts going up. So it drives, their respiratory center is where?
Thalamus? No.
Medulla. And so that's going to drive them. Okay. The other thing to remember is alveolar ventilation is inversely proportional to their, well, it should be the other way around. PaCO2 is inversely proportional to their ventilation rate. Okay, you all told me that very thing. Ventilation goes down, CO2 goes up. Okay. Again, it's because they cannot move air in and out of those alveoli. Mucus plugging, bronchiolar constriction limits airflow. The blood keeps going around the alveoli, but there's nobody home to pick it up and take it out or to deliver more oxygen, okay? See how that happens? All right, I knew you did. Okay, look at that number two, the number 4 bullet. So when if you have a pulmonary or arterial CO2, then if it's normal, in this situation, that's bad, okay? They can't respond any longer to those elevated, or their airways, they cannot pick up their respiratory rate, they cannot move enough air to get rid of that. Shouldn't be normal. They should be, with those CO2 levels going up, they ought to be very tachypnic and they ought to be driving it down, right? CO2 levels should be low, right, Julie? Right. Okay. So, progressive hypercapnia is, in exacerbation of asthma, is usually an indication to ventilate them. Okay. Really important. These people can go south very quickly. So observing them, watching those markers that you can measure, and their overall appearance is really important because they can die on you very quickly. Okay. So have you all talked about venous sampling of CO2 versus arterial sampling? Okay. Is that something you all will be covering, Professor Reggio? The venous monitoring of CO2 versus arterial?
That's something with the ABGs I'll have to get into. I haven't looked at the slides in detail. I'll look into that.
Okay, so my understanding is that we always did arterial sticks, but they're very hard to do. They're painful. You have to be very adept at it. But my understanding is now they're using more venous sampling because it's easy to get at. And it's fairly consistent. It's reliable. It's a good predictor of CO2, much easier to get.
Dr. Latassi?
Yeah.
I was confused by that 4th bullet.
Okay.
Why would the CO2 be normal? Why wouldn't it be high in the blood if they can't blow it out?
Say that again.
Wouldn't you expect their PaCO2 to be high? If they're in exacerbation and can't blow off their CO2, why would it be normal as an indicator of failure?
Because their ventilation, the mismatch in that is so off now that it's not going to show up. Does that help?
Does that mean they're not getting air in, therefore it's not getting out, but it's kind of equalized because they're not getting any in either?
They are.
That's all.
I think I've stated it right. Because the respiratory center is no longer going to drive them. So that high CO2, they should be driving it down, right? So as your CO2 levels are going up. So if it's rising and their respiratory rate is dropping, that's the problem, okay? Because the higher CO2 should be constantly driving them to, you can't ever correct with the lungs by yourself an acid-base disturbance. So with CO2 levels rising, their rate ought to be able to compensate for that. If it's normal, they can't compensate any longer. Make sense? Respiratory drive cannot get the lungs to get rid of that CO2 enough. So in a situation where you would expect it to be low, it's normal or high. That's impending respiratory failure. Everybody got that? Sorry. Sorry for the confusion. Chest x-rays, not normally done unless you suspect that something else is going on, okay? If you look at their chest x-ray, they're going to be hyperinflated because they're air trapping. But in the first scenario, you saw they looked for pneumonia. They suspected pneumonia. So how would they present that would make you think about a pneumonia?
Fever.
Pardon?
Fever?
Fever, okay. What else?
They can't lay back and breathe, they have to sit up and breathe.
Okay, so that would also, they're gonna be doing that anyway. So if they look sick, if they are febrile, if there's prior history, maybe what someone can tell you happened a few days before they came in, would make you think there's probably an infectious source. That's important. If you can identify the trigger that is also contributing, you have to treat it as well. Okay, so let's finish up with assessing risk for fatal infection, then we'll take a break. So fatalities in this country tend to be from lower socioeconomic, non-white urban areas. So I wrote a paper several years ago on epidemiology on asthma. What is so overwhelming in the literature is that it's usually inner city folks most at risk, ethnic groups most at risk. So when you look at the kind of problems that exist in that area, is that usually if you are dealing with moms of single moms or single parent, multiple children in a home, often they are not able to attend to a disease that requires a lot of attention. I related a story to you when I taught you about asthma, about a mom that I had that came in, single mom, she had 3 children. And her oldest child was the one I was seeing, he was 8 years old. We sat down and I said, so how's he taking his medicines? He had been prescribed inhaled corticosteroid and albuterol. Mom said, I have no idea, you'll have to ask him. So I asked the little boy, how are you taking your meds? I showed him, we laid him out. He wouldn't talk to me, he was too shy, it was too scary, I guess. So I tried to engage the mom more, and she just said, look, I have 3 kids, her oldest child, her middle child was a special needs. She said, all my attention goes here. He has to do it on his own or it won't get done. And I'm thinking, 8-year-old. To put that on an 8-year-old. So eventually, I got the children out of the room and I talked to the mom a lot about developmentally, he's just not there. So we had to set up a way for him to get his meds that was going to be more guaranteed that he would get them. So you can get that sense that if you've got one child that has a lot of needs versus others, somebody gets shortchanged in the whole thing. So getting kids to the doctor. So I already told you that the average number of missed days is 13 days. If you are having to see them frequently for that or for other reasons, it takes them out of school more. When I set up my appointments for kids with asthma, I always do it at 4 o'clock in the afternoon because I waited until they got out of school. That doesn't always happen, so that can be a problem. If the mom is working and she has to leave work to get a kid and then bring them to you, it can be a problem for them as well. So the underuse, the under-accessing of medical care, even if it's there, may be way underutilized. The other is just recognizing the disease itself. A lot of patients, if you look at their asthma, they way underestimate their own dyspnea. So they don't realize how badly their asthma is controlled. Also, when you're dealing with urban kids, inner city kids, it's usually pollution is more, air quality is poor compared to people that live in the country. So that adds to it, car pollution. And it's also their living conditions. I told you I wrote lots of letters when I was taking care of people of asthma up to their landlords. It's like, it's really important that you change the filter, at this often. It would be very helpful if you would exterminate the roaches in your apartment building. Because if you kill them in this apartment, they just move to the next one. So their living conditions aren't always good. They may not have the funds to take care of their place. I saw lots of kids with asthma because mold. The house would flood, They took care of that, but then the mold set in, now we got that. In this state, we don't have the problem with basements, but basements are often a problem because they get moldy and dank. Where do you send the kids to play in the winter? Down in the basement. That's where my mother sent us because we had a great basement. But it wasn't finished. So it's those kinds of environments that really do lend itself to worsening of asthma control, and kids get in trouble. 70% of deaths due to asthma are preventable or have a modifiable risk factor. That's why it's so important that you assess that and work with them on how they can change that or control it. Sometimes they don't have control over all of it. Look at on slow onset fatal asthma. This is the most common form. The 2 pharmacy students that I told you that died from a slow onset fatal asthma. It's a history of progressive symptoms over more than 12 hours and usually over weeks. That's why, if you can recall back when we talked about asthma, I talked about using peak expiratory flow rates to monitor, especially people who have very varying, have wide swings in their peak expiratory flow. That usually happens after an exacerbation. Okay, so they may be 80 plus one day, but the next day they're in the 70s, or the next day they go into the 60s and then they bounce back up. Maybe they take their meds one day, maybe they don't take them the next. It's that variation and that decline over a short period of time that peak expiratory flow rates can pick up. Peak expiratory flow will decline over 72 hours before a patient ever has an exacerbation, symptoms of an exacerbation. So it's predictive. So use those and use that in patients who have wide variability, have lots of exacerbations, or non-adherent. It's hard to get them to do, but if you can get that data and teach them how to use that to prevent, it's worthwhile. Let's see. So those changes over days to week, really important. That's why telling them, you may feel good one day, you skip your meds for a couple of days, you can be in trouble by the 3rd or 4th day. The drug they're most likely not going to take are inhaled corticosteroid. It doesn't change in the way they feel. They can't tell it does anything when they take it. I had a lot of problems with junior high boys taking it. They were already in senior high. They were like, no, it messes up my muscles. Couldn't get to do it. Had to use lots of negotiations on getting them to use it. It also is, it's usually something to do in the morning and nights, twice a day. So that's a problem, getting them to do it in the morning when they get up and do all their stuff, doing it before they get to bed. That's important. So most of the people who die with fatal asthma, it's usually they had sufficient time. There was sufficient time for somebody to recognize it and do something about it. You look on the next page, these are risk factors. There's a table at the bottom that kind of summarizes those things. I want to go through this. Recent or poorly controlled asthma. The people who are at most risk for dying are those that you have to admit that go to the ICU that are intubated. Their risk of dying from asthma is significant for the next 18 months. Okay. That is the best time to get them in with an asthma educator or an asthma specialist is really important. Those are the highest risk, intubated, ICU. The next most critical are those that you had to hospitalize. The next are those who go to the emergency room frequently for breathing treatments. The next are the ones that show up in your office frequently for breathing treatments. Okay? So it's a gradation, it's a continuum. Pay attention to those people. Their airways are not controlled. Okay? If you don't have the time to help them, and they do take a lot of time, then get them into a specialist. I put another study down there just to drive this home. So these are that second bullet. A study of patients discharged after mechanical ventilation for near-fatal asthma showed a mortality rate of 10% at 1 year, 14% at 3 years, 23% at 6 years. In 6 years, a quarter of those people are dead. Okay? Pay attention to them. Usually as an asthma educator, the best time that I could get people's attention was after a hospitalization. Very best. Do you know what my show rate for that group was? 25%. Once they feel good, they don't come back, okay? It is